Hi guys, this is Dr. Patil, your faculty for internal medicine at Physics Wallah MedEd, and in this special video module, I would be discussing about life with internal medicine in general, with a little bit of focus on how's the life going to be if you choose internal medicine residency. Now, what am I going to cover in this module? I'll be addressing importantly three areas. Number one, what is internal medicine? You should certainly know what is internal medicine because you hear these terms like internal medicine, general medicine, family medicine. Do they all mean same? Do they all have the same scope of practice, or they are different entities? Number two, I will tell you whether you need to do a super specialty training, DM or DRNB, or is it enough to do a MD or DNB medicine to sustain your livelihood in a current cutthroat practice scenario. Number three, we will also take an insight into how's the life going to be once you join internal medicine residency, right? Let us do one by one. First, let me address the first point. What is internal medicine? Okay, obviously this is not a didactic video, and certainly I'm not going to teach you the theory or a definition of it, but I'll give you an idea what is internal medicine. Primarily, internal medicine is that branch of medicine as a whole where we try to focus on diagnostics, primarily like from the symptoms, taking it to the definitive diagnosis, and then medical management of diseases. Now, the scope of internal medicine had been expanding in the recent times, so it is not restricted to the medical management of diseases anymore, and interventions have made their way into internal medicine also. The only thing that we don't do in internal medicine is open surgeries. Otherwise, various internal medicine specialties, for example, gastroenterology, right? Gastroenterologists do the sclerotherapy for the esophageal varices, which is an interventional procedure, right? Similarly, they can do various endoscopic procedures. The pulmonologists, who are again specialists related to internal medicine, who do various bronchoscopic interventions. Cardiologists, you all know, do angioplasty and then various other interventional cardiology procedures. So medicine is no longer restricted to being medical management specialty of diseases, right? We do interventions in the internal medicine. Only thing that we don't do, as I have already told you, is that we don't open up for surgeries. Okay, so the scope of internal medicine is wider than we think. The only limiting factor is your capabilities and your skills. If you acquire skills to do any interventional procedure, you can do it. Okay, so internal medicine basically is a specialty which focuses on diagnostics and medical management, and the scope is expanding into interventions. Now, is internal medicine and general medicine same? Well, the globally accepted term for this branch indeed is internal medicine. Somehow in Asian countries it was like transcribed into being general medicine. General medicine and internal medicine, from the Indian perspective, they're exactly same. There's no difference between the two. But if it comes to family medicine, it's a different branch. What is the difference? Now, when it comes to family medicine, they are also reasonably well trained to be an internist or a physician, but not sufficient enough to handle complex cases. So during family medicine residency, a family medicine resident is trained to handle the average emergencies and day-to-day cases, but not the rare cases. The rare cases are trained to refer to appropriate specialty. And remember, an internal medicine resident will only be trained in medicine, and he will not be trained in ob-gynae or general surgery or pediatrics. On the other hand, a family medicine resident gets trained in pediatrics, ob-gynae, general surgery, trauma, orthopedics. So they are like, family medicine is an extended version of MBBS where you learn little more about key specialties. Now, if you ask me, sir, which one is superior or which one is inferior, I'm nobody to tell you an answer, because we definitely need good family medicine doctors in the country, because family medicine is the solid, I would say, the spine of healthcare system. If there are no good family medicine practitioners, an internal medicine super specialist or any other specialist will not be able to give or deliver good care to the patients. So please do not be under the impression that one branch is inferior to other, no matter what comparison you're looking at, whether it is internal medicine versus surgery, or internal medicine, family medicine, pediatrics medicine, family medicine, pediatrics, OBG. No comparison is possible. Okay, so because we need all the specialties, all we need to understand is what's my calling, where I resonate better, that is the specialty you should be choosing for, and not based on somebody's opinion that something is superior or something is inferior. Clear? Okay. Now the second point. So sir, if I take up internal medicine, do I need to go for DM, or is it okay to settle with the MD or DNB medicine? Few things to learn here. Now DM is a super specialty which is of 3 years duration in India. Post 3 years, your post MD or DNB medicine. Post MD or DNB. Now there are different DM courses available in India, and you may or may not be eligible to a particular DM branch depending on whether you've done your MD or DNB in medicine or other specialties. Okay. So as of now, if you have done MD medicine or DNB medicine, that makes you eligible to do DM courses or super specialty courses in various specialties. Okay. So I will make a list of few important one of them. Okay. So you can do DM in cardiology, which as a child, mostly we always dreamt of becoming a heart doctor or a heart surgeon if you take up MCH from cardiac surgery side. Okay. Then you can do DM in nephrology, DM in neurology, DM in gastroenterology, okay, DM in infectious diseases, DM in oncology, DM in hematology, DM in pulmonology, DM in critical care medicine. Okay, so the list goes on and on. Newer specialties are being added into it. Now, if you do MD or DNB in general medicine, you're eligible for all these. And also remember, like, it's not only the DM, and also a super specialty from NBE called as Doctorate of National Board. Both are considered as equivalent. Please don't be under the impression that DM is superior or DNB is inferior, or DNB is superior and DM is inferior, or for that matter, even MD or DNB. Legally, technically, they're all equivalent except for teaching. If you want to get into a medical college and become a teacher, there are certain restrictions with respect to DNB or DRNB, because there, the law of the land or NMC Act mandates that you should have one additional year of senior residency before you become an assistant professor. Especially if you've done your DNB or super specialty DRNB from an institute which had less than 500 beds. But if you've done it from an institute which has more than 500 beds, and in that place you had at least 2 guides who are considered as equivalent to professors according to the NMC Act, then you don't need to do any additional year of residency. You will be flat out considered equivalent to MD or DM. So you don't have to really worry if your institute has 500 beds and has faculty members who qualify to be called as professors according to NMC guidelines, who have requisite teaching experience. If not, you might have to do an additional 1 year residency, but trust me, that's not a big deal at all. Always choose a branch over the specialty. I'll tell you the reason. See, first rule number 1, the medical college salaries today are meager. If you establish your practice well, then you can make that money even from 2 days of your practice. So none of us will be able to sustain our lifestyles of being a doctor, or will not be able to meet the society's expectations if we only rely on medical college salaries. And with going forward, trust me, medical college salaries are not going to increase anymore. The reason for that is the number of PG seats have increased, and more and more number of people are available to become teachers in medical college. So there's no competition. There's competition from the teacher side. The colleges are not competing for teachers, so obviously they're not going to offer you fat salaries. And second thing is that the difference between a senior resident salary and assistant professor salary may be 5,000 to 7,000 rupees. At worst, maybe 10,000 rupees. Okay. Second difference is that in terms of the job responsibilities, there's no difference. A senior resident and assistant professor are almost technically equivalent. So if that is the case, right, for that 10,000 rupees difference for 1 year, why should you choose a branch that you don't like, right? Always choose the love of your life. Always choose a branch which you love. Don't go into this DNB, MD equivalence and all. It doesn't matter. Well, I do agree that the DNB may be a bit difficult to pass But there is a glitch here, or there is an issue here. What is the issue? See, DNB are mostly conducted in institutes which are not traditionally academic, and they may not have an academic orientation, or the faculty or the consultants might be excellent physicians, excellent specialists, but they may not be tuned to teaching, right? So you may not feel like, okay, I'm learning something new every day, but a little bit of extra effort, you will be at par with an MD. And it's so not difficult to pass DNB if you stay focused. Stay focused. And see, remember, once you get into residency, even in medical colleges today, nobody is going to spoon feed you the knowledge or information. It's all based on your effort. Learn the ability to read books. Okay, so there is no simple solution to reading. You might have got used to watching videos and listening some quick revision programs to get through your NEET PG exam or NExT exam, but that may not work once you get into residency. Residency is a full-fledged commitment to a specialty. Harrison has to be your second love. Obviously, first love, whoever is your first love. Then the other thing is that consistency holds the key regardless of what exam you're preparing. So even DNB or MD, if you read consistently, you will sail through just like that. But if you don't, right, that is where you will get into the trouble. Okay, so I hope I have made that clear. Now you're eligible for all these specialties, and if you're already decided that, okay, I'm going into these specialties, you may have some shortcuts. See, getting into internal medicine may or may not be easy depending on your preparation level, but if you still crave to be a cardiologist or a nephrologist, you have alternate pathways apart from internal medicine. What are the alternate pathways? Number one, okay, let me list the specialties in which, as a pediatric resident also, you will be eligible to write the entrance exam and become an adult specialist. Examples, right now, cardiology, nephrology, neurology, okay, infectious diseases, oncology, pulmonology, I'm not sure. We need to check from time to time. See, these specialties you can get into even if you do your MD pediatrics. So if you're missing out medicine, but you're very clear that you want to do a DM, you can get into pediatrics, but make sure that once you get into pediatrics, be dedicated towards your entrance exam preparation, which is called as NEET SS, NEET Super Speciality, NEET SS. Okay. So stay focused. Why? I will tell you. See, you can become a cardiologist even after pediatrics and adult cardiologist. You can become adult nephrologist, adult neurologist, adult infectious disease specialist, and adult oncologist. Other specialty you may be eligible. The rules keep changing from time to time, but the exam that you will be writing for NEET SS will be based on internal medicine, because you're trying to get into an internal medicine specialty, right? So it will be based on internal medicine. So you have to still read Harrison even if you get into pediatrics. That level of commitment if you have, you can take a pediatrics route to get into these DM specialties. Alternate pathways are also available for other specialties, right? Pulmo DM you can also do after your MD or DNB respiratory medicine. So if you're sure that I will go into DM Pulmo, you can also do MD or DNB respiratory medicine and you can get into DM Pulmo. Similarly, when it comes to critical care, your MD or DM Pulmo, MD or DNB Pulmo, apart from medicine I'm talking about, right? DNB Pulmo, I'm not very sure as of now whether pediatrics is eligible. Most likely pediatrics is eligible. Okay. And your emergency medicine. Emergency medicine. Now these specialties will make you eligible to get into even DM critical care medicine. And also I forgot to mention, most importantly, majority of the people who get into critical care medicine are from anesthesia background. MD, DNB anesthesia also makes you eligible to get into critical care medicine DM. What to remember here? Because Pulmo, critical care medicine, they're all listed under medicine, right? You would be writing a NEET SS, especially for critical care medicine, you will be writing a NEET SS based on internal medicine only, right? So again, even if you get into Pulmo, pediatrics, emergency medicine or anesthesia, to land up with a DM CCM seat, you need to study Harrison based internal medicine. So if you have that level of commitment, you can take alternate pathways. If not, like I can't manage my pediatrics preparation as well as the medicine preparation for my NEET SS, then better to stick to medicine route. That is a safe and tested route. Okay. Clear? Now coming to the real question, is it okay to settle with MD medicine or doing DM is mandatory? What do I think? Well, there are few changes. So when I was doing my residency, the average number of the MD or DNB seats in an institute used to be 2 or 3. So like a medical college used to have 2 or 3 MD medicine seats. A DNB institute used to have 1 or 2 DNB medicine seats. The time has changed. Now institutes have 20, 30 MD medicine, 6, 7 DNB seats per institute. And that makes the supply of physicians abundant. According to me, personally, it is more than adequate. Now that might put some of you in a situation where like, will I be able to survive with such a cutthroat competition? I'll tell you some important points which are based on my experience. As of now, if you look at all the NEET PG allocations of last 3 or 4 years, you will always notice that medicine has constantly remained within top 3 branches sought by the top rankers. Yes, there are dermat, radio and other branches, but medicine has maintained its position within top 3. And that had been the case since my days in 2009 till now. I can say that medicine had always maintained the position in top 3 when it comes to toppers choices of specialties. Why so? The reason is, see, the medicine will never go out of fashion. Why it will never go out of fashion? Simple reason is because in India we don't have a thriving family medicine practice, right? You become the first point of contact. Like if you have any family member who is sick, right, most likely you will go to an MBBS doctor who had been your family doctor, or you will land up with your family physician who is most likely going to be an internal medicine specialist. So internal medicine specialist becomes the first point of contact, and then whether he can handle it or he should refer to an appropriate specialty, he decides. And because that is the architecture of healthcare system in India, medicine will not go out of fashion. But few points to remember here. If you want to settle in metro cities, you might have a bit of difficulty. I'm not saying that you will have difficulty in sustaining your profession. Okay, you will be able to sustain your profession, you will be able to sustain your lifestyle even with cutthroat practice. But if you have to buy land, build a house, build a hospital, that may be difficult in the today's context in metro cities. When you move to tier 2 cities, things become a little easier. You can have a better lifestyle, better savings, and better better lifestyle management. The issue will be that the payment per consultation will be much less. So you will make more money by seeing more number of patients. So you will have less time for yourself. Okay. Then third, you can also move to tier 3 cities, which are basically taluka places, right? The sub-district places. There you can literally establish yourself as a well-established practitioners. You can dethrone an existing practitioner, or you can exist with an established practitioner at equal forefront. Now at that location, you will have good flow of money, but you may lack a bit of practice satisfaction because you don't have the advanced resources. When you want to get an MRI done or a CT done, it may or may not be available at your disposal. You might have to refer the patients to nearby tier 2 cities or the metros. That compromise would be there, but still it might give you a better satisfaction because you always stay connected to society, your patients, and you're not seen as an separate individual. You're part of the society, especially in tier 3 cities. Okay. Now you can make a choice. Settling in tier 3 city is easiest. Number 2 easiest is tier 2. Metro is a bit of struggle. You can always make a choice, but make a choice soon after your residency. Don't rotate trying. Like, okay, I'll spend 3 or 4 years in metro. Let me see how it works. If it is not working, then I'll spend 2 to 3 years in a tier 2 city. Let me see if it works. No, if it is not working, then I jump to a tier 3. No. Right after your residency, if you've decided that I'm sticking to general medicine, decide your place of practice, shift there, and give your dedicated, sincere effort on practice for 3 to 4 years, and hopefully you will be well settled at the end of that. Okay. So I wouldn't say that DM is mandatory. There will always be a need of non-specialist. Because see, generally one more thing is that a specialist over time develops a tunnel vision. I should not be saying that I agree being a non-specialist, but a specialist over time might develop a tunnel vision. For example, a chest pain for a cardiologist is almost always of cardiac origin, right? He may not be quickly thinking about the other non-cardiac causes. Well, in cardiac cases, it makes sense because The cardiac causes are common and they are emergencies in comparison to non-cardiac cases. But similarly, a headache for a neurologist might only mean a neurological cause. So that gives a tunnel vision or a narrow vision towards the diagnosis. So ideally, a case should be routed through a non-specialist, maybe an MBBS or an MD internal medicine, so that an appropriate differential diagnosis is taken into consideration. And fortunately, that's what happens in India. Most cases get routed to specialists through the physicians, and that as long as that architecture is maintained by the society, medicine will not go out of fashion, and you don't need to worry whether I should really go for DM. Majority of the people go for DM only out of peer pressure. It's like, okay, I had been a topper in my MBBS, I got a government medical college MD, or I got a good DNB institute, I passed it in one attempt or two attempt. Now at my level, I should definitely go into super specialty. That's the mindset that we create often, and that mindset draws many people to DM and not the real need for so many DM or DRNB specialists. Whether they are happy post DNB, DRNB or the DM, that's another question. So interact with specialists to understand their life's perspective. I can say that I know a lot of super specialists who went into super specialty just because of the peer pressure and they literally regret it. But at the same time, I also know a lot of MD or DNB medicine who are fairly happy with their general medicine practice. And I also know people who have done super specialty, superb, happy, rocking because they were passionate about that particular specialty. And I also know MD or DNB who are doing internal medicine practice, but they're not happy with that. So it at the end of the day boils down to who you are and what is your calling. Go for super specialty if it is your calling. Don't just go because of the peer pressure. Just avoid peer pressure. That's it. It's not mandatory as of now to go for DM. That's my take on it. Okay, now coming to the last part, what's the life during medicine residency? Because I have given you a picture of life after residency, but will I be able to survive the residency? Because I keep hearing about stories of medicine PGs committing suicide. Recently there was a story of a third year medicine PG committing suicide. So is it really harsh? Is it impossible to tolerate? Is it such a difficult residency? Okay, now if you ask me what is the most difficult residency, without any hesitation, I would say Obgyne. I personally consider them as saintly souls who are dedicated to mankind than themselves, because I've seen Obgyne residents, their work schedule, hecticity, and see, if you finish your residency, at least after that, if your life is chill, maybe okay, fair enough, you're putting an effort to make your next life better, not next life, I mean the next few years of life better after your residency. No, once you finish Obgyne residency, after that life is going to get more hectic. So literally they are more committed to their patients than themselves and their family. In comparison to that, medicine is a much better specialty. Well, in medicine you're almost always on your toes because we also deal with emergencies. Though there is a thriving emergency medicine department, after stabilization you will be called, and ward calls when there are an emergency, generally they will be routed to medicine resident itself. So life is going to be hectic during residency. It's not going to be like the internship days where you could easily escape from one place to other. Does that mean that I should start my day early at 6 a.m. and end at 11:30? Possible, depending on your institute. I know on paper there are rules that this should be the working hours, but unfortunately many institutes it's not followed, and it's not the fault of the institute or the faculty members. At times it is, but not always, because workload is so much, right? Someone has to cater to those patients. We can't let patients suffer. It is the humanity's cause, right? So be prepared to expect a bit of hardship during these 3 years of residency. Okay, it may be physically grilling. I will help you how to deal with that in a separate video, and if you have issues you can personally ping. If you're a resident and you're watching this video, I will help you to deal with it, like how to manage your time, how to manage your personal relationship during residency. Those are altogether different topics. We can talk about it a lot, but right now just remember that life for next 3 years once you get into medicine residency is going to be hectic, but not as hectic as Obgyne, sometimes not as terrible as surgery, because sometimes in surgery you might have to stand in the theater from morning to evening for a single surgery or multiple surgeries lined up. It's not going to be that busy, but you're always on your toes and your brain needs to be always working, because okay, that patient's this report came, this patient's that report came. You need to keep processing, right? You will train your brain to be a mastermind for sure. Okay, then if you love medicine, then this hecticity wouldn't be a roadblock. For first 3 to 4 months, I know all residents crib about, sir, I'm not getting time for taking a bath, I'm not getting time for having my breakfast. That's a routine, no need to worry about it. Just sail through. Survival is the important aspect of your residency. Somehow survive. Once you finish, right, you can make your informed choices, whether I want to be a busy physician or whether I want to be a chill physician. Choose your practice place, choose your kind of patients, choose your working hours according to that. But during residency, you may not have a choice. Now, the awareness of doctors' health, residents' mental health, this increasing in all institutes, among the faculty members, your peers, and residents. So, hopefully, in the near future, we will cater to resident stress and anxiety in a better way. But for now, it is going to be a bit stressful. Be prepared, but in the end, it is rewarding. Okay, so with this, I'm signing off this video module, guys. I will be doing more video modules for you to understand how to deal with day-to-day issues in internal medicine residency, and we will do a small video on one day in an internal medicine resident's life. I will try to interview one of my internal medicine PG students so that you will get to know how is it life, how the life goes on during your residency. Right? Signing off, guys. Thank you.